We're going to move to the next speaker, Dr. Lieberman. Then he's going to talk about should cardiologists own sleep apnea management in AFib patient and beyond.
Okay, thank you very much, everybody, for coming. The disclosures. My goals today are very simple. It's going to be to convince you that sleep apnea is not a pulmonary disease, but it's a cardiovascular risk factor. I think the simple way to understand this, sleep apnea's relationship to a pulmonologist is about the same relationship as syncope is to a neurologist. And I think you'll see that this is truly a cardiovascular disease. And we're going to look at the necessary tool that we need is a simple tool that we can broadly apply to all our patients so that we can differentiate and risk stratify a patient snoring versus obstructive sleep apnea. Now, as you listen to this, you have no idea. Is that snoring just something that is annoying to you? Does it represent something that's annoying to you and the dog in the room? Or is it representing a risk factor for potential stroke, death, myocardial infarctions, atrial fib, and all the comorbidities? It all sounds the same. Now, sleep apnea or obstructive sleep apnea is a very simple process that the soft palate becomes narrowed. And it can either be from anatomical reasons, it could be from something so simple as just as we'll see fluid shifts, or it can be from obesity. But any time that you have snoring, you have obstruction. Now, people have never really tied and put the dots on the I's and the T's for you. But as simple as having peripheral edema at the end of the day, and then you go to sleep, and you wake up, and everybody in our patients tell us, what happened to the peripheral edema? It disappeared. Well, what it did is it redistributed, and of course, gravity takes it, and it can significantly lead to sleep apnea. There are numerous studies that have been out there that have clearly shown that just the redistribution of the fluid can predict your risk of sleep apnea. Sleep apnea, we score it. For those of you who aren't used to doing this, we get reports, but most of us in EP don't really study the literature, and we get what we call an AHI score. And what we simply do on this is we take the amount of times that you have a decrease in airflow, a decrease in oxygen saturation, how many of these episodes are greater than 10 seconds, depending upon how much decrease in oxygen saturation there is. We either call it apnea or hypopnea. We total those up per hour, and we give you a score. 0 to 5 is considered normal, 5 to 15 mild, 15 to 30 moderate, and above 30 considered severe. The typical sleep study is done in an inpatient center, as you know. Most patients don't like to go there, and usually there's an EEG to monitor brain activity for arousal. There's a band placed around the waist to look for movement, to tell the difference between obstructive and central sleep apnea, and then we have EKGs and O2 saturation. And this shows us what a normal versus an abnormal sleep study would look like. Just because most of us don't look at these, we get reports. Here we see a normal one where we see the heart rhythm, blood pressure very stable. We see the chest and the abdomen moving together. In the patient, when they become obstructed, we see that there's no longer any airflow. There's a significant rise in blood pressure. Systolic blood pressures probably can reach 200 to 230, 240 millimeters of mercury during these. It's an enormous adrenaline output. That adrenaline output is necessary to save your life because it wakes you up. And we see arousal. So if we look at the EEG of these, we would see an arousal, you wake up, then you go back to sleep, and you repeat the same process. One thing that's also you notice is that the chest becomes paradoxical. And this is very important for the mechanisms and many of the outcomes with sleep apnea. One of the things that happens is when you become obstructive and you're taking this enormous breath in, is you get increased venous return to the right side of the heart. You have increased afterload because the blood pressure is going up due to the adrenaline response. And so now what we do is we see this venous return. It shifts the septum towards the left of the heart. We got pulmonary hypertension. We have increased outflow obstruction, decreased cardiac output, microinfarctions, as we'll see, all leading to the pathological outcomes with sleep apnea, all from a cardiovascular outcome, as we'll see. As you've heard, sleep apnea carries mortality risk. This was early recognized back in 1988. People with sleep apnea, even moderate, AHI greater than 20, die more often than people without sleep apnea. Furthermore, when they took a look at it, we see a graded or a dose response with sleep apnea, further substantiating this effect. We see as we go from an AHI of 5, 15 to 20 to 30, we see increased mortality in every study. But notice, even mild to moderate sleep apnea carries an increased risk of mortality. The mortality early on was thought to be due to the patients being woken up all night and they're tired during the daytime. Automobile accidents are significant. Greater than 800,000 car accidents in the United States in 2000, 1,400 deaths, $15.9 billion, and this was when the incidence of sleep apnea was probably 1/3 or 1/2 of what we're diagnosing currently. Because of this right here factor, it makes it impossible to do a randomized clinical trial with sleep apnea. How could you ethically take a patient at risk of automobile accidents on the road and do a randomized clinical trial with CPAP? It is eliminated because of this factor, most likely the ability to truly do randomized clinical trials out there on sleep apnea. When we look at the mortality a little bit further, what we see is that both fatal and non-fatal cardiovascular events are increased with significant sleep apnea, fatal and non-fatal cardiovascular events. Hypertension, when the patient walks into your office on more than 2 antihypertensive medications and is hypertensive, it should trigger to you, does he have secondary hypertension due to sleep apnea? It should be the first thing that you think about, and they should be worked up for this. As we further worked up and as the history and the story of sleep apnea moved on, we moved from the cardiovascular, overall cardiovascular events to the identifiable as an independent risk factor of sleep apnea for stroke. Sleep apnea is an independent risk factor for stroke in our populations, and it is both non-embolic and embolic. Sleep apnea is clearly associated with embolic strokes. Any patient that has a cryptogenic TIA or stroke, and there's some people in the room that should listen to this, anybody with cryptogenic TIAs or strokes, it has been long time a class 1 indication that they should have a sleep study to diagnose the etiologies and mechanisms of their stroke. As we heard, there's association or maybe an independent risk factor of sleep apnea of atrial fibrillation. Being at an EP meeting, all of us, we need to be aware of when we hear of our patients with arrhythmias, VT, VF, occurring in the nighttime hours, you should immediately be thinking of sleep apnea. They have an opposite pattern of the patients without sleep apnea. Sleep apnea also, when we take a look at it with cardiovascular diseases, for all of our interventional friends and all of us being cardiologists, we should be aware it is a driver of cardiovascular disease. As we look at low, moderate to severe sleep apnea, the calcium scores go up significantly. The risk of cardiovascular disease is associated with sleep apnea or an independent risk factor for it. And coronary plaque burden, intimal thickness in the carotid has all been shown to be a risk factor with sleep apnea. Furthermore, for all of our colleagues doing interventional procedures, their outcomes, just as we saw with atrial fibrillation, are so highly dependent upon sleep apnea, so is all of our interventional procedures, restenosis and poor outcomes in MESAs for all of the interventional procedures. And when we look at this a little bit further for all of us in the EP worlds, we see that ischemic and non-ischemic cardiomyopathies, the mortality outcomes are driven highly by the presence of sleep apnea. We can summarize this part and say simply obstructive sleep apnea is independent risk factors. When left undiagnosed, the risk of stroke doubles, the risk of fatal cardiovascular events goes up by 5 times, and the risk of serious vehicle accidents, as I showed you, increases. It's associated as independent risk factors: obesity, diabetes, congestive heart failure, acute myocardial infarctions, atrial fib, hypertension, stroke, depression, and probably in the future even erectile dysfunction. What part of that is a pulmonary disease? There is no pulmonary diseases associated significantly with sleep apnea. It is a cardiovascular disease. So the question is, how do we get from snoring to these cardiovascular morbidities and mortalities of which I've shown? What is the connection of how you go from snoring to all of these cardiovascular outcomes which I've shown you? Cardiovascular diseases, the sine qua non is obviously lipids, myocardial infarctions, and plaques. That's the background, and how is this mechanism related? Well, most of us sort of still sit in the world of where we think we go out, we eat donuts, McDonald's, and then what happens is these donuts and McDonald's get in our blood vessel, and they decide to clog up the blood vessel, okay? That's the EP's version of atherosclerotic heart disease. Well, as we all know, I hope by now, it is a subintimal disease. Atherosclerotic heart disease and cardiovascular disease is all occurring beneath your endothelium. It is not an intraluminal disease. The key buzzwords for those of us in the EP that aren't used to looking at this disease are 3 simple words: dyslipidemia, abnormal lipid particles; oxidation, something attacks those lipid particles and makes them more prone to an inflammatory response; and then myocardial rupture or plaque rupture. Those 3 components, and what we have to look at in these next couple of slides is how is sleep apnea promoting these aspects of it. So remember, it's a subintimal disease. An ApoB LDL particle goes from intraluminal to subluminal. The more LDL particles that you have, the more likely that they go subluminal. The smaller that these LDL particles are, the more prone they're going to be to oxidation. The more prone your LDL particles are to oxidation, the more likely you're going to have an inflammatory response by the macrophage, creating the foam cell with the negative outcomes. It's a very simple process. For those of you not interested in lipids, remember measuring an LDL, as you know from the ACC, is no longer adequate, and it's for this reason. 2 people can have the same LDL, 100 milligrams per deciliter, but depending upon your particle size, you can have totally different numbers of particles. And as we now know, the more particles, the smaller the particles, the more you are prone to oxidation, inflammatory responses, and poorer outcomes. LDL goes from the lumen, it comes beneath the cells. Once it's beneath the cells, it could sit here and never be a problem. But if it becomes oxidized or modified, it triggers inflammatory responses and cytokines that now take your monocytes that are just moving through your lumen, and these adhesion molecules triggered by signals from these oxidized LDLs. We get VCAMs up here, adhesion molecules, and these monocytes now stick to the endothelium, slow down enough so that they're going to be able to come through the lumen. As these monocytes come beneath the lumen and this oxidized LDL, they attack at the macrophages, start to dissolve the proteins in it, and form a foam cell. And this is the sine qua non of the inflammatory response leading to the cardiovascular outcomes. Furthermore, we can monitor this inflammatory response. LDL carries a particle on it called L-plaque, as you know, now approved by the FDA to monitor inflammatory responses. The LDL becomes beneath the lumen, gets attacked by the macrophage. Once it attacks it, it liberates L-plaque back into your lumen, and you can now monitor the inflammatory response. So you now can tell whether your LDL is sitting there hibernating or it's an active inflammatory process. L-plaque has been associated with cardiovascular outcomes, and it's specific. CRP is a nonspecific inflammatory marker. L-plaque is specific to arterial disease and stroke. So how does sleep apnea tie into this process? Let's take a look at this in 3 quick slides. The first thing that happens is when you have intermittent hypoxia, not chronic hypoxia like living in Denver. Intermittent hypoxia triggers what we call hypoxia-induced factors. These are proteins that get triggered on or altered by low oxygen content on and off, which then causes the production and the increase of lipids, specifically VLDL, the initial particle endogenous process made by the liver circulating increased particles. These particles are also converted over to small LDL. Here we see increased particles, and then what we see is increased small LDL particles related to sleep apnea. And remember, it's the small LDL particles that are more prone to oxidation. So now we got our substrate. We got the LDL, we got increased lipids circulating in the bloodstream. We have smaller ones that now get beneath the lumen, and they're more prone to oxidation. Intermittent hypoxia, such as with sleep apnea, has now been shown to be a promoter of one of the highest risks for oxidative stress in the body. Okay, this is the same thing as when we look at reperfusion injury. We get intermittent hypoxia that activates these free radicals, and as you know, the free radicals can either damage the cell directly or can turn on a series of proteins that go to the nucleus of such of the cells underneath the artery to cause the inflammatory process. The specific processes that it turns on are called cytokines, chemokines, adhesion molecules. Remember, we talked about the little chemical messengers calling the monocytes in, the little messengers slowing down the monocytes so that they can get attracted into subluminal. Notice, it's all being triggered by the intermittent hypoxia, turning on the free radicals that then go to the nucleus of your cell and trigger these chemokines and cytokines. Here we see CPAP, or we see sleep apnea, with the increased messengers, and here we see when we turn on CPAP that we can decrease these messengers. We decrease the messengers, and we see here CPAP increasing L plaque, and then when we give the patient CPAP, we see that we turn off the inflammatory response to these patients. And more so than just turning off inflammatory responses, turning off markers, if we take a look at a group of patients with a high risk of fatal and non-fatal cardiovascular events. So here's our patients with no treatment. When you compare them to the group treated with CPAP, they return to the control group or baseline risk. We can reverse this process by identifying people who snore and identifying their cardiovascular risk. So snoring is a vital, modifiable risk factor for cardiovascular morbidity and mortality. Reducing cardiovascular morbidity and mortality in our practice requires differentiating snoring from obstructive sleep apnea. A simple and broadly applicable test that differentiates and risk stratifies snoring is necessary to impact the cardiovascular mortality and morbidity of disturbed sleep. You should ask every single patient in every EP practice everywhere the stop bang should be on the wall of all cardiovascular practices. This acronym, snoring, tiredness, has anyone observed you to either stop breathing or snoring? Blood pressure, do you have hypertension? Your BMI, age greater than 50, neck circumference, male or female gender. If you have 3 or more, you are absolutely indicated for screening for obstructive sleep apnea. And of course, now with Itamar, we can do this through the outpatient setting, and that we can start to really tackle cardiovascular outcomes. Thank you very much.
So, Randy, how much of all that you talk about come together with the reality is most of these patients with sleep apnea have metabolic syndrome. So how much of that is the obesity, how much of the sleep apnea?
His question is about metabolic syndrome. And so it is components, but when you take a look at all the studies that I showed, and when they adjudicate things for the independent risk factors, metabolic syndrome does not impact the sleep apnea. Patients with metabolic syndrome are going to be more prone to have sleep apnea because of their obesity. Okay, but you do not need to be obese to have this. Okay. Okay.
Thank you. Any more questions from the audience? Otherwise, we'll go. Thanks, Randy. Thank you very much.